And now Isabel Lusada, our president and CEO at ARC. She's going to just give kind of an overview about the state of the market.
Hi, good afternoon and welcome everybody. And we're really glad that you could join us today. Just by way of background, I know many of you know about ARC, but for those of you who don't, the Amyloidosis Research Consortium is a non-profit that is focused on accelerating the development of and access to new and innovative treatments. So we strategically develop and invest in a prioritized portfolio of research that's most likely to have the biggest impact on improving quality of life and length of life for patients. And to do that, we work very closely with all stakeholders, and that really means with patients to ensure that we really meet the research is meeting their needs, as well as with the experts, physicians and clinicians and researchers, and also the companies, the industry that's working in the field, the pharmaceutical companies, as well as with regulatory, so the FDA in the US and European Medicines Agency in Europe. And then with payers, because part of our commitment is to make sure that these new treatments that are developed come to market and patients have access to treatments. And we're also committed to supporting patients throughout their journey with the disease. So it's an amazing time in the history of amyloidosis where for the first time we actually have an approved treatment specifically developed for amyloidosis. This is for ATTR patients with hereditary ATTR with peripheral neuropathy, polyneuropathy. And we will have in the near future, a high likelihood of 2 other therapies being approved. And one for the same group of patients and one for cardiomyopathy patients. This brings complexities that for the first time we are dealing with patients being prescribed treatments that are specifically for amyloidosis. And there's a high cost associated with these. And so we know that there has been great concern from patients about how they'll be able to afford these treatments. So we're really excited to have Beth Halpern as a speaker who specializes in helping healthcare clients achieve coverage and reimbursement for innovative technology and advises payers on policies and develops strategies to improve access to care. So this webinar is really based on presenting an overview and not specific to the programs that patisiran might have, which will be known as, the market name will be Onpattro, or inotersen, which will be marketed as Tegsedi. So any questions you have should be not specific to those particular treatments. If there is a question you have and you want answered, feel free to reach out to ARC and we will be able to help guide you in getting the right answers to those questions. So I'd love to now hand over to Beth to take the lead on her presentation. And thank you very much, Beth, for joining us.
Thank you, and thank you for asking me to speak today. I'm happy to present these slides and hopefully answer some useful questions at the end, if we haven't covered everything in the slides, and I doubt we possibly could. So I will get started. So I can get the slides to move. There we go. So first, when trying to understand what a patient's out-of-pocket costs or other cost-sharing obligations will be for any therapy, you really need to understand what kind of insurance you're dealing with, whether it's for yourself as the patient or a family member, or if you're in a medical practice, what your patients have. So we're going to go over the different types of health insurance that are most commonly used and most likely by amyloidosis patients: Medicare, Medicaid, private insurance, how those programs structure their benefits and the cost sharing requirements differently depending on how a patient gets a drug, where the drug is administered, or where the patient receives it, whether it's through a doctor's office, a hospital, or a pharmacy. And in the case of Medicaid, it can vary a lot depending on what state you're in or how you qualified for the program. And then we'll talk about what options exist to help patients with their out-of-pocket costs and what could change with all of the other changes happening in our healthcare system right now. Not only changes in access to health insurance, but what plans are covering and how they are trying to manage the costs of new therapies. We'll start with Medicare because Medicare is the single largest health insurance program in the US. There are actually a few more people enrolled in Medicaid than in Medicare, but Medicaid, as we'll talk about, is really 51 plus different programs. For Medicare, is more or less one big program for people over the age of 65, people with disabilities, and people with end-stage renal disease, meaning patients who are on dialysis. It's organized into 4 different parts. And if you're a Medicare beneficiary, you have your card, it says Parts A and B on there. Or if you chose to enroll in a Medicare Advantage plan, that's Part C. You would have maybe a different card for that. Part D is the prescription drug benefit coverage. And these parts actually refer to parts of a federal statute. It's not just how it's organized, it's how the law is organized. And the cost sharing, the enrollment requirements, what kinds of benefits are covered are different under each of these parts of Medicare. Medicare Part A is hospital insurance. And bear in mind that when the Medicare program was created in 1965, healthcare was delivered in different ways than it is now. Patients were in the hospital a lot more as inpatients than they are now. And so the first part of the program Congress set up was for hospital care. And this covers when you're an inpatient in the hospital, skilled nursing facility care, if the patient goes to the skilled nursing facility after a qualifying hospital admission, home health services, and hospice, among some other things. Most people who have Medicare are automatically enrolled in Part A when they turn 65 or after they receive Social Security disability benefits for 24 months. Patients who become eligible for Medicare because their kidneys fail have to actually take proactive steps to enroll. Most patients don't pay a premium for Part A, but if a person didn't pay Medicare taxes while working, or they didn't pay them for enough of their working life, you have to basically work 10 years, but not necessarily straight in a row, it's 40 quarters over your lifetime, then you would pay a premium up to $422 a month. But for most patients, they're not paying a Part A premium. Under Medicare Part A, and this is relevant to some drug therapies, if you have to go to a hospital and be admitted as an inpatient, for example, to get that drug. Some new therapies do require patients to be hospitalized because they either have higher risk profiles or they're given to patients who are already sick enough that they're in the hospital. Your cost sharing for those services is a little bit complicated to describe because it's not based on the individual service. It's based on what are called benefit periods, a time period that starts when you've been admitted to a hospital. And there's a benefit period deductible that applies to each one of these admissions. So if you go to the hospital today, everything that happens over the next up to 90 days is considered one benefit period. And then if you go a little while without going back to the hospital, a new benefit period starts and you'd have a new deductible and new cost sharing. So the initial deductible in each of these benefit periods is $1,340 for the first 60 days of hospital inpatient care. And then there's per day coinsurance starting at $335 for the next 30 days and $670 per day for the days after day 90. And if you personally have dealt with this or you dealt with it with a family member, I was recently dealing with this with a family member where we were watching the calendar very carefully and counting how many days it had been since the admission and then the skilled nursing care and so forth, figuring out when they would run out their time. Skilled nursing facility cost sharing, the first 20 days are covered in full after the patient has been in the hospital for 3 days, and then it's $167.50 for each of the next days, 21 through 100. Home health and hospice have their own different cost sharing. I think home health, I don't think has any cost sharing actually, and hospice has a small coinsurance of 5% for inpatient respite care. So you really have to be very conscious of when a patient is an inpatient, where are they being treated? How long have they been in this setting? How long ago did this benefit period start? And you'll find that especially in skilled nursing facilities, the staff there are also very attentive to this. In Medicare Part B, this is the part of Medicare that covers physician services and hospital outpatient services. It's called medical insurance. The enrollment here is automatic for most people. If you become eligible for Medicare and you already have coverage from another source, like you're still working or you have veterans benefits, you might be able to choose to delay enrolling in Part B without paying a penalty. But if you don't have some other what's called creditable coverage and you delay enrolling in Part B, you pay a 10% penalty for each year that you didn't enroll from when you were first eligible. Generally, this enrollment period runs January 1st to March 31st each year if you don't sign up right when you first become eligible for Medicare. And there are special enrollment periods under certain circumstances. For example, if a person was working past age 65 and then they stop working, they get a special enrollment period. And as I said, this is covering your physician services, including the physician's work when you go to the hospital, outpatient services, including outpatient surgery, emergency room visits, durable medical equipment, and really importantly, for what we're talking about today, certain physician-administered drugs. So the drugs that you go to the doctor's office and they either inject or infuse into you, for example, those are covered under Part B. Cost sharing under Part B is divided into the premiums, the per month amount that a patient generally pays to be eligible for, continued Part B coverage. There's a deductible, and then there's co-insurance on the services that patients receive. The standard premium is $134 a month, but it can be adjusted upward for income, as shown in the table here. So patients with the highest income levels pay up to $428 a month. And it can be adjusted downward for patients based on their Social Security benefits. So the deductible is $183 per year. And after that deductible is met, beneficiaries pay 20% of the Medicare approved amount. So you'll see, you get these explanations of benefit documents. You go to the doctor's office, the doctor charges $500 for your visit, but Medicare actually only approves $200. You pay 20% of that $200. For care that you get in a hospital outpatient department, there's actually a cap on how much the copayment can be, and it's limited to the inpatient deductible amount. So if you go to the hospital and a drug is infused and it's more expensive service, let's say, it's not uncommon to get a $20,000 drug administration service. You're not going to pay 20% of the $20,000. The patient's out-of-pocket is capped at $1,340. There is, however, no maximum on your out-of-pocket costs. And this can be quite a burden for some patients. So within Part B, the amount the patient has to pay for services depends on where they got the service. And this, again, is because Congress did not create an easy program for us all to implement. In physician offices, patients generally pay 20% of what the doctor's allowed charges are on the bill. The drugs they get in that setting are reimbursed based on a formula that creates something called the average sales price, which is based on manufacturer sales within the US, plus 6%. So the patient pays 20% of that price. In hospital outpatient departments, the payment rates that are paid to hospitals are set through a sort of complicated system of grouping services together and identifying the average cost for those services. In some cases, drugs are separately paid, in addition to the drug administration service or the clinic visit or other services rendered on the same day. And the patient would pay 20% of those costs. The drug would be separately reimbursed, so 20% of the drug, 20% of the clinic visit, and the other services. But as I said before, there's a cap on the cost sharing at $1,340 per what's called an ambulatory payment classification per group of services. And honestly, this is not at all transparent to patients. So I know that the current administration, as some of the previous administrations have been, is trying to work toward making pricing and hospital charges more transparent. So maybe there'll be some improvements on this in the next couple of years. What it means as a patient ultimately is you get this bill and then you get an explanation of benefits that shows here's what the hospital billed, here's what Medicare actually paid, here's the 20% that you're left being responsible for. And as we described earlier, that is all quite different from how cost sharing is set up for hospital inpatient services, where each hospital admission is grouped into a payment category based on what the patient's diagnosis was. The drugs are generally not separately paid, they're built into that. So you could be a hospital patient and get that $20,000 drug we talked about. You don't get a bill separately as a patient for $20,000. It's just built into the overall costs and payment for that hospital admission. And your cost sharing starts at $1,340 per benefit period. Medicare Part C is also known as Medicare Advantage, is a different way for getting all of these Medicare benefits. It's an option for Medicare patients. They can choose to enroll between October 15th and December 7th of each year. And what these plans do is it's like a way of getting all your Medicare services through a health insurance plan, like an HMO or a PPO. They're required to cover the same services as original Medicare, and they have the option of covering additional services like vision, hearing, and dental that aren't covered by regular Medicare. And some of these plans include prescription drug coverage all in one plan, so you can sign up and get everything all in one place. These are becoming increasingly popular. In 2017, a third of all Medicare beneficiaries were enrolled in one of these plans. And you can see from the map, they are really popular in some states. California and Oregon have really high enrollment. Some states, especially in the, in the upper Midwest or the Western Plain states, have lower enrollment based on how many plans are available and what benefits they offer. There's a lot of variation in these plans, not only how they're structured, there are 4 main types of plans, but what benefits and additional benefits they offer. I know if you, like my mother, you watch the Golf Channel a lot, we see a lot of ads for these plans on TV and offering, the vision benefits and gym memberships and things like that. But that can vary depending on which kind of plan the MA plan is offering, is an HMO or a PPO, for example, and what the competition is like in that market. And they also can vary a lot in terms of cost sharing. And this is really important if you're a patient who's considering enrolling in one of these plans, that you are not going to have necessarily the same out-of-pocket costs that you do in regular Medicare. They might be higher, they might be lower. There is a maximum out-of-pocket limit that doesn't apply in regular Medicare, but you may find on some services you're actually getting them for pretty much no cost compared to regular Medicare, and others might have higher costs. You have to look at the plan options that are listed in this plan finder. We have a picture of it here. Each year, and particularly be very sensitive to which drugs you need or which kinds of services you think you're going to need more of, and do that analysis. And I know some physician offices have staff and hospitals have staff whose job is in part to help patients do this analysis. And Part D is the prescription drug benefit. This is something that you can enroll in addition to regular Medicare. You can either have choose Part C that has the drug benefit built in, or you can keep conventional Medicare A and B and add Part D, the drug benefit, separately. Like Medicare Advantage, these plans are run by private insurers, and they can vary a lot in coverage and cost sharing obligations. You can use the same plan finder website to find information about them. It has a neat feature, if you haven't used it before, where you can plug in the drugs you use and the pharmacy where you want to get them, and it will show you what the cost would be for those drugs. And it has open enrollment every year from October 15th to December 7th. The cost sharing in Part D, there is this structure in the graph here on the left that's kind of like the standard. This is what plans can do, but they can also change their cost sharing as long as it's actuarial equivalent to this. So this is what it would be if you just everybody followed the same template, but it doesn't always work quite this way. So in the standard model, there's a $405 deductible, meaning the patient pays everything up to that first $405. Then in what's called the initial coverage period, the patient pays 25%, the plan pays 75%. And then you hit the coverage gap, or the thing that's sometimes known as the donut hole. And in that period, the amount the patient pays will depend on whether it's a generic drug or a brand name drug. And if it's a brand name drug, the patient currently would pay 35%. This number is being phased down to 25% over time. If it's a generic drug, the enrollee pays 44%. Once you've hit a maximum out-of-pocket limit for the year, you hit a catastrophic threshold, and the patient then pays 5% of the cost, and Medicare and the plan pay for the rest of the costs going forward. So your true out-of-pocket is supposed to be capped at $5,000. Even if your plan shuffled the cost sharing around a little bit differently, but it came out to be what's considered actuarial equivalent, you'd still have that $5,000 limit, I believe. For patients who have low incomes, there are subsidies available under Part D. These are referred to as extra help in some of Medicare's resources. And in fact, when you go to the plan search website, or even if you go to the plan finder for the Affordable Care Act, it'll ask, do you qualify for extra help? This is what they mean, these subsidies. They apply to patients who have limited income and resources. There are two ways you can qualify. One is to be deemed eligible, which includes people who get Medicaid, Social Security, supplemental income, and Medicare savings program, and we'll talk about that in a moment. Or you can apply if your assets and income are below set levels. The subsidy is paid from Medicare directly to the Part D plan. So the patient this money isn't going through the patient's Social Security checks or through their bank. It's paid from Medicare to the plan to help with the premium, deductible, and co-payments. If you're in the full low income subsidy group, you have no premium and your co-pays are limited to from $3 to $8 and no co-payments at all in the catastrophic coverage phase. If you're partially eligible, you have reduced premiums, 15% coinsurance compared to that 25 to 40%, 44%. And your catastrophic copays are limited from $3 to $8. And this is open for enrollment any time of the year through the Social Security Administration. So particularly if your circumstances change during the year, this is a great idea to look at changes in your resources, especially if you suddenly find yourself, on a much tighter budget or losing a source of income, to go analyze what your options are and see if you can enroll for something in the middle of the year. Other options for patients who qualify for Medicare, you might have employer-sponsored insurance, particularly if you're still working, or maybe you have a retirement plan, which can be used in addition to Medicare. If you're still working and you have your employer's coverage, Medicare is secondary to the private coverage, meaning you use your employer's benefit first, and Medicare helps pay the cost sharing and other out-of-pocket costs left behind by that plan. Dual eligibles are people who are eligible for both Medicare and Medicaid, and items and services that aren't fully covered by Medicare could then be covered by Medicaid. It can pick up your remaining cost sharing. And there's also something called the Medicare Savings Program. Well, I'll show you a little bit more about that, as well as Medigap policies or Medicare supplemental policies. The Medicare Shared Savings Program is a program that exists under Medicaid, uses Medicaid money, but it helps pay Medicare premiums, deductibles, and coinsurance for certain people based on their income and asset limits. There are two different big programs here, the Qualified Medicare Beneficiary and the Specified Low-Income Medicare Beneficiary programs. They have different parameters in what they pay for. The QMB program pays for all of your premiums, deductibles, coinsurance. And then there are income and asset levels set for the different programs. Specified low-income Medicare beneficiaries pays only for the Part B premiums and has yet slightly higher income and asset requirements. This is all extremely complicated. I don't think Medicare actually expects patients to understand any of this at all. However, the state Medicaid program is supposed to understand it. If not your physician offices, at least hospitals almost always have staff whose job is in part to figure out who qualifies for these programs and help people sign up for them. There's also a program called the Qualifying Individual Program with yet slightly higher income and asset requirements. It pays for your Part B premiums and patients have to reapply every year. And then for qualified, disabled, and working individuals, this is a program that pays your Part A premiums. It's for people who are working disabled people under the age of 65 who lost their premium-free Part A coverage when they returned to work and they're not getting state medical assistance. As you can see, this is very much a patchwork quilt of options to cover people. Our healthcare system, to the extent it really is much of a system, evolved in fits and starts, and this part of how Medicare and Medicaid work together is really a creation of acts of Congress over many years to kind of fill in gaps, but it still left holes. And that's why you really need help from those experts who can help you work through what resources and income you or the patient you're working with have and find the program that fits them. Medigap is available to everybody, assuming you can afford to pay for it. These are Medicare supplement insurance policies, and they are widely advertised on TV, especially in the middle of the day on the Golf Channel and HGTV, the things my mother is watching. They are a supplement to original Medicare. They don't replace Medicare. You buy it in addition to Medicare. and you can't sign up for them if you have Medicare Advantage. Medicare Advantage is supposed to sort of replace this. You don't get both. They're offered by private insurance companies. They charge a monthly premium, and the policies are standardized, so you can easily compare the benefit packages from one program to another. I'll show you a slide in a moment that compares the different kinds of benefits. They generally don't cover long-term care, though, or private duty nursing. So some patients then will have separate long-term care insurance on top of that. These policies are guaranteed to be renewable, which means you can renew them despite having health problems, but there are limited circumstances under which you can enroll without what's called medical underwriting, or having to provide medical information that could increase the premiums or cause relatively sick people to be denied coverage. At your initial open enrollment period, for the 6 months after a person becomes eligible for Part B, there is no medical underwriting. You can just sign up. They won't ask you about your health conditions, and they can't adjust your premiums based on it. But if you wait past that, you might have to answer those questions. There are certain circumstances where you have a guaranteed issue right to buy the plan after open enrollment, including if your insurance plan ceases to exist or ceases to cover your service area, or you exercise your option to try a Medicare Advantage plan and come back to original Medicare within the first year. You should be careful if you're considering dropping Medigap coverage for Medicare Advantage or another plan, because you might face higher premiums or denial if you come back. And I've heard this from some of the financial assistance people who work with patients at some of our, within some of our client organizations, that they have patients who sign up for Medicare Advantage when they're relatively young and healthy, thinking this is great, I love to get the vision benefits and I'll use the gym membership. And then they get, they unfortunately, develop a more serious illness. The Medicare Advantage plan they chose doesn't really fit their options very well, and now they're not eligible to enroll in Medigap, or it'll be more expensive. So the policies, as I said, are standardized, and they're grouped together. They're identified by letters. So if you want to compare the cost of, say, a supplement plan C, it's going to be the same benefits across any company. That makes it a lot easier to compare the costs. What this chart shows you is how much of the costs in these different categories are covered by each of the types of Medigap plans. So for example, if you chose the F plan, it's going to cover 100% of your Part A coinsurance and hospital costs, 100% of your Part B coinsurance, 100% of your hospice care coinsurance, 100% of your skilled nursing facility, your Part A deductible. It won't, if we're in the F plan, it will cover your Part B deductible as well, and any excess charges. And it will even cover travel outside the US, but it doesn't have an out-of-pocket limit. Other plans, K and L, for example, can have out-of-pocket limits, but they cover less in each of those categories. Now, turning to Medicaid, as I mentioned before, Medicaid is really 51 plus different programs, but generally it is a jointly funded federal state health insurance program for low-income and medically needy people, including low-income adults, children, pregnant women, elderly adults, and people with disabilities. Most states offer fee-for-service coverage and managed care plans. Some are moving more and more toward managed care, and some, like Arizona, I think the only thing available is managed care. The eligibility and coverage varies from state to state, and you've probably heard a lot about this in the news, well, going back to 2010 when the Affordable Care Act was passed, about whether states would expand their Medicaid programs or not. They were given the option under that law to expand eligibility to people at slightly higher but still low income levels who previously wouldn't have qualified. For the lowest income adults, each state sets its income and asset thresholds, and they can vary a lot. Some states you actually have to be well below the poverty line to qualify. Others went through the expansion and you can be up to 133% of poverty. Medically needy patients may be able to spend down their income by showing that they have significant medical bills that reduce their income to a certain threshold. And generally this eligibility is based on periodic review. So Medicaid will review the patient's expenses sort of while they're underway, but it's not permanent. So if the patient either gets better and their healthcare costs drop, or they have another source of income become available, then they might not qualify anymore. However, Medicaid enrollment is available at any time, with a few exceptions we'll talk about. Generally, and hospitals, I think, will want to examine a patient's information if they find they have a patient who's uninsured or underinsured and see if they can qualify for Medicaid. What's actually covered when you're in Medicaid? Well, there are certain mandatory benefits that all state Medicaid programs have to offer, including inpatient and outpatient care, physician services, lab services, x-rays, other imaging, and home health services. And there are optional benefits that include prescription drugs. Prescription drugs aren't mandatory under Medicaid, but all states actually cover them. Your out-of-pocket costs for Medicaid are limited, by design. This is a program for people with particularly low incomes. They don't have the resources to spend 20% of a $20,000 drug. Some groups are exempt from out-of-pocket costs entirely, including children, patients in hospice, and patients who contribute all of their income towards institutional care costs. And certain services are exempt from co-payments, including emergency services, family planning, pregnancy-related service, and preventive service for children. Medicaid programs can charge limited premiums and enrollment fees to certain groups of people, including pregnant women and children with incomes above 150% of poverty, qualified disabled and working individuals above 150% of the federal poverty line, and medically needy individuals. And they can impose co-payments to incentivize generic drug use. If your income is above 150% of the federal poverty line, co-payments for non-preferred drugs, which are often brand name drugs, may be 20%. For patients with incomes below that threshold, the co-payments for non-preferred drugs are limited to nominal amounts, and that's usually just a couple of dollars. State Medicaid agencies can also set different co-payments for mail order drugs and for drugs sold in a pharmacy. Like commercial insurance does, sometimes they really want to encourage use of mail order as a more efficient way of getting drugs to patients. And they can impose higher co-payments if patients go to the hospital emergency room for something that is not actually an emergency. States have the option to seek what's called a waiver, which lets them change aspects of their Medicaid program, generally with the goal of making it run more efficiently and hopefully, expanding access to care. These programs can include things like higher co-payments for non-emergency use of the emergency room, and they can adjust cost sharing if you exhibit certain healthy behaviors. Indiana, for example, has a program that requires beneficiaries to pay small monthly premiums into an account, which is then supplemented by the state and are used to cover the initial expenses under $2,500. It's meant to give patients some, quote, skin in the game, that they actually see how the money is being saved and spent for their healthcare services. The table here shows some of the examples of healthy behavior incentives and other changes to co-payments and cost sharing that states have implemented or are considering. The Trump administration has shown a lot of willingness to consider changes in these programs, particularly to follow the Indiana model. However, recently Kentucky had a program that among some of the changes listed here would have also had a work requirement, and that was invalidated by a court, in part because the purpose of these waivers was to expand access to Medicaid, and the work requirement was found to actually drastically reduce Medicaid enrollment. The court said that was not compatible with the purpose of the statute. But other incentives that have been implemented by other states and are still in place, things like increasing copays above the statutory limits, charging patients fees if they miss their appointments, eliminating non-emergency medical transportation, but then reducing coinsurance if the patient displays certain healthy behaviors, which can include things like taking smoking cessation measures, waiving preventive care costs for 19 and 20-year-olds. And in Texas, they're looking at restricting patients' choices of family planning providers. So now we'll turn to private insurance. And private insurance is a big, confusing market in the United States. Still about half of all Americans, maybe a little less, get their insurance through their employers. And then about 8 or 10% more get it through private insurance through the Affordable Care Act exchanges. There are some requirements for what the plans under the Affordable Care Act or Obamacare have to cover. But generally, cost sharing varies by plan and often within a plan by drug and by service. And when you're looking at drugs in particular, plans can use tiered cost sharing, so they lower the co-payments for preferred drugs and raise them for non-preferred drugs. If you've ever been to the pharmacy and you hand over your prescription and they tell you, oh, this is in tier 2, and you just picked up a drug where you paid $3 and now they're asking you to pay $15 for this other drug. It's because they got put in different tiers, for example. And drugs can be preferred or non-preferred, not just based on their clinical literature and research, but sort of how much they cost. It's a bargaining technique between health plans and pharmaceutical manufacturers. Specialty drugs, particularly the biologics that are used for chronic conditions and cancer drugs, may be placed in a tier with the highest cost sharing. Sometimes that's not expressed in terms of dollars, it might be a percentage of the drug cost. Drugs that are furnished in physicians' offices and hospitals might have yet more differences in cost sharing than drugs obtained through pharmacies because they're paid for under a different part of the plan's contracts and benefit structures. Patients who have high deductible plans, where you kind of exchange, hopefully reducing your premiums for having more out-of-pocket costs up front, may then have to pay more for those drugs up front. Their healthcare costs over the year in total will actually be lower. And there may be separate deductibles for prescription drugs than for other services. So as a patient, if you're counting down toward your deductible, you may have to look at your drug costs separately from your physician and hospital service costs. But there may also be limits on your coinsurance across the board. And the thing is, with thousands and thousands of health plans offered across 50 states plus DC, there are a lot of variations in these plans, and you really have to look very carefully at what your plan is offering and what limitations it has. And when you're considering changing plans from year to year, how a change in plan would affect the coverage of the services and the drugs that you need most. If you find that all of this is still, and it often happens, that even with all these different health insurance options, or maybe because of all these different health insurance options, patients are still left with really high out-of-pocket costs, particularly for new drugs. And it's very common for pharmaceutical manufacturers to offer patient support programs, including assistance with co-payments for drugs. However, some of these programs are prohibited in certain states. California and Massachusetts, for example, prohibit copay assistance for patients with private insurance in certain circumstances, particularly if there's a generic drug available. And copay assistance is prohibited across the entire US for patients with federal health insurance, including Medicare and Medicaid, veterans and military benefits, TRICARE. So there are these copay cards. You might see them advertised in the doctor's office or at the pharmacy or even sometimes on TV. But if you're a Medicare patient or Medicaid, you can't use those. You might, however, be able to get assistance from something called an independent charitable foundation, which are these organizations that are, as it says, independent and charitable. Manufacturers make contributions to them to then help patients, and there's supposed to be some safeguards, some walls between the contributing manufacturers and the foundation and how they distribute the money. On top of that, if you're getting care in a hospital, hospitals often have discounts or policies to deal with patients who can't afford their out-of-pocket costs. The patient assistance programs, however, are under scrutiny. There has been a lot of, obviously, attention in the news and from lawmakers in the last couple of years about high drug prices, both drugs that come onto market at high prices and drugs that used to be less expensive, but their prices have gone up rapidly over time. And this year, the Trump administration has announced that it plans to take some significant measures to do something about that. They released a plan called a blueprint this spring that was actually a list of about 20 pages of questions of different things the administration was considering doing to get feedback on those ideas, including limiting patient assistance programs and trying to encourage manufacturers to just set lower list prices to start with. In addition, some of these programs have been under scrutiny because although there are supposed to be separations between the manufacturers and the foundations, some companies came under investigation and entered into settlements because they were alleged to have improperly channeled donations to patients through the foundation, rather than handing the money over to the foundation and having it be handled in kind of a hands-off way. So if these programs end up getting removed or scaled back, it could have a big impact on patients and their choices and their incentives to choose different drugs. If you no longer have access to manufacturer copay assistance, you may need guidance from your healthcare provider on other financial options available. And that need may arise quite suddenly because there have been frequent changes in the law. And as companies either come under investigation or face more scrutiny, they can of course change the terms of their programs at pretty much any time. So first up, I would always suggest if you feel sticker shock on seeing the cost of the new drug is of course to talk to your healthcare provider. If they hopefully have heard about the patient assistance programs that are being offered, if there is one. If they haven't, look at the drug information, find out who manufactures that drug, go to their website, see if they have information available about the patient assistance program, and give them a call if your healthcare provider's office doesn't, to figure out, do you qualify and what might be available for you. Usually when new drugs launch, if they're particularly launching at a relatively high cost, and they're serving patient populations that haven't had treatments before, the companies put time and energy into setting up these programs to help patients get access to the drug when they need it. And finally, I'll offer a brief summary, and then I'm actually a little bit ahead of schedule here. I'd be happy to take questions. Key things to take away from this is that your cost for a new drug can vary a lot depending on the type of coverage you have, what kind of health insurance you have, and where under that health insurance the new drug would fit, and the types of financial assistance that are available for you. So with the new drugs that are in the pipeline that Isabel was talking about, I think at least one of them is going to be administered in physician offices. Another one I think you might get through pharmacies to make it a Part D benefit. They would have very different cost sharing and may have differently structured patient assistance programs too, reflecting the different kinds of costs and the ways patients incur those costs for the drugs. The things that determine whether a patient's eligible for assistance or even whether they're eligible for a certain type of health insurance, like their income, their marital status, their medical debt, can also change, and sometimes can change rapidly over the course of a year. So it's a good idea to stop periodically and check, what do I as a patient qualify? What, if you're the healthcare provider, what do my patients qualify for? Have my circumstances changed that there's something I could take advantage of now that I couldn't use in the past? In fact, this is a conversation I've had with my own family members. And bear in mind that the terms of your health plan, including Medicare Advantage and Part D, can change from year to year. A drug that might be really well positioned under a Part D benefit in 1 year, in terms of what its cost sharing is and where it's on the formulary, might not be as well positioned the next year. So it's a good idea to sit down in that open enrollment period. And lots of conversations families have over Thanksgiving weekend and look at what drugs you need, what drugs you think you might need, and whether your costs would be better if you change plans for the next year. And of course, the coverage and eligibility requirements for federal healthcare programs can be changed, either by federal law, by changes in regulations, by states that are looking to either expand their Medicaid programs or use waivers and other authority to actually limit the programs and add premiums and cost sharing. And as I mentioned, there's the drug pricing blueprint that looked at various measures to try to reduce costs for drugs, including moving certain drugs from Medicare Part B to Part D, changing cost sharing, trying to encourage manufacturers to use fewer discounts and just lower the prices, for example. So there's a lot of potential changing pieces in this landscape, and it kind of requires patients and their families and their providers to stay on their toes and keep constantly evaluating what's the best way for this patient to get the care they need. And with that, I would be happy to take questions.
That was wonderful. So just a reminder to everybody, feel free to use the Q&A box at the bottom of your screen to ask any questions, and we'll go ahead and provide those to Beth. We did receive one question. It was in relation to the Medicare portion of the presentation. And the question is, for infusion treatments, which may be outpatient hospital service, for each infusion treatment, depending on the cost, a patient may be liable up to $1,340 per treatment. And they're asking if they got that right.
They did. Let me go back to the slide where that was explained. Way back here. So here we go. So when you get services as a hospital outpatient, You go in for the infusion, you have on your bill, you would see a charge for the drug, a charge for the infusion service, like actually setting up the IV line and putting the drug through it, having the nurse watch you and so forth. You may have other services that happen on the same day. Say you had a check-in with your doctor, you had a visit, you might have had some lab tests run, or maybe some imaging services. This $1,300, $1,340 limit applies to each, more or less, each line on the bill. So if you had an MRI that day, your limit on the cost sharing would be $1,340. MRIs, fortunately, don't have cost sharing nearly that high. But for a drug, what that means, there's a special rule that applies to drugs, that they take the combination of the charge for the drug and the charge for the infusion service, or the payment for the infusion service. So let's say Medicare's total payment for your drug was $20,000 and your infusion was, let's say $500. Break out my calculator here. So you have $20,500. Your out-of-pocket cost, if it was 20%, would be $4,100. But because it's capped, CMS combines the drug costs and the infusion costs and makes that all one service and limits your out-of-pocket costs for that day to $1,340. And the difference between the $1,340 and the $4,100 is picked up by Medicare. So Medicare actually makes up the difference. The hospital's made whole, it's just you have to pay less. But bear in mind that limit, that $1,340, is per day. So if you're getting a $20,000 infusion today and you go back in 4 weeks and have another $20,000 infusion, you're limited to $1,340 per day that you get the infusion.
So we did have just a quick follow-up, and I apologize if you did cover this. In addition to that question, would the Medigap policies cover the difference? So is the liability up to the $1,340?
Just a second. So what Medigap covers, depending on which plan you choose, is all of your coinsurance. So if your coinsurance is capped at $1,340, they pay the $1,340. If you're in a different setting of care, like in physician offices, your coinsurance isn't capped. If you got that $20,000 drug in the physician office, you would have to pay for you get this bill for $4,100. Medigap would cover all of that, assuming you chose one of the plans that's 100% of your Part B coinsurance or copayment being covered. So in most Medigap plans, once you paid for the plan, you are not paying out-of-pocket costs on your Part B services, and most of your Part A up to 365 days after your Medicare benefits are used up.
So that's great information. I did want to just quickly ask, I know you mentioned in the beginning of the presentation, it's just very complex information that is provided, and I know that a lot of the patients just have a lot of trouble understanding it, and you had mentioned that most places have staff on site that are responsible for explaining this in plain terms to patients if they have questions. Could you want to just touch on that again?
Sure. And I would say in my experience, both personally and what I've seen from working with clients who are both healthcare providers and drug manufacturers and some groups that represent combinations of types of providers, you're probably more likely to have this kind of assistance available in a hospital or in some larger medical practices. Like oncology practices tend to have this because they have years of experience dealing with higher cost therapies and patients who simply, there's one person I was working with said the other day, nobody, Warren Buffett maybe, but almost nobody in America can truly afford the cost of their healthcare, even if they have health insurance, once you get to certain types of care. So cancer patients, and cancer would just be financially devastating for almost anybody. Other treatments, we don't know what the pricing is going to be like on the new drugs for amyloidosis, but other treatments where you're dealing with complex and new therapies increasingly present economic challenges to patients, to put it mildly. So some physician practices have staff that help navigate this. Others, I think, are looking at the fact they need to start hiring more of those staff. Hospitals generally have these people on board already, and their jobs are in part to sit down with patients and figure out, here's what your bill is going to be, or here's what your bill already is. So they're sometimes not as transparent as one would like before you get the bill. Let's figure out what your insurance options are. With Medicaid, for example, when you enroll, it's actually retroactive. You can enroll now and it will have covered your costs for the last month or so, maybe even, might even go back a little bit further than that. Medicare has a similar thing. If you're, well, actually kind of provides to providers, but once they enroll, they can get their services paid going back a little bit. Medicare generally, it starts on the day you become eligible. But hospitals and physician offices increasingly have these financial support people who are around to help you with this. And if they don't proactively come out to you, you should reach out to them and say, I'm worried. We're talking about putting me on this therapy. I see what it might cost. You've told me what it might cost. How am I going to help cover that? How am I going to be able to afford that? And they can help walk you through that. I know, again, in my own family, having had these conversations with family members where I looked up the number in the hospital and called and said, okay, who do we talk to about how to cover the next phase of this treatment? Or looked up the manufacturer's website and said, okay, there is a patient assistance program for this particular drug. Here are the qualifications, here's the number to call. And you'll find that those figures I was showing, for example, for Medicaid eligibility, which are really low percentages of the federal poverty line. You're looking at people with incomes, family of 4 and an income under $20,000 a year might be priced out of some of these programs. But some of the drug patient assistance programs have much higher thresholds. You can be up to something like 400 times the federal poverty limit and still qualify for assistance because the cost of the drug is so great compared to most people's incomes. So, if you're not getting immediate assistance from the physician's office, try the hospital, try what other, see if they have anybody else available. Of course, see if there's support from foundations and research groups that are out there. Try the manufacturer too and see if they can help navigate you through this because this is complicated, but there should be people out there, particularly in the healthcare providers who need to get their bills paid too, who can help you with this.
It looks like we have another question that just came through. What is the poverty level income?
That is a great question. And as I was realizing I was talking about this, I always have kind of a ballpark in my head, but I better look it up again. And I think there are some adjustments per state. So for this year, if you are a household of one person, what's the federal poverty limit or federal poverty guideline is $12,140. So that's the income threshold. These numbers are updated every year. 100% of FPL, as we had on some of the slides, is $12,140. For 2 people, it's $16,460. Family of 4 is a little higher than I thought. It's $25,100. And so a lot of Medicaid eligibility and those Medicare Medicare savings programs and so forth are pegged to multiples of the federal poverty limit or some fraction of it. Go to Medicaid, for example. Like here, 150% of the federal poverty line. So for a single person, your income was below $18,000 a year, you might qualify. That's where the line is at 150% of the federal poverty line. So.
Thank you for that information. It looks like that's a wrap on the Q&A, unless we have some stragglers that come through.
Sure.
We did want to just thank you again for delivering this presentation, and thank you to everybody for attending. And just to let everyone know, we will be sharing it in the near future as a resource on our website. And so if you've registered for the webinar, we'll be letting everybody know when that's available. If your question wasn't answered quite the way you wanted it to be, and you have further questions, you can feel free to reach out to ARC at arc@arci.org, and we'll try to do our best to get back to you as soon as possible.